So picture this. You've got a patient in front of you, their eye is painful, it's swollen, maybe it's completely cloudy. Traditional visual exams, they just hit a brick wall. You literally cannot see past the surface. But what if you could peer right through all that opacity? What if you could map out the intricate structures hidden inside and do it using completely non-invasive technology? Well, that is the incredible power of veterinary ocular ultrasound. Welcome to this explainer. I am so excited to get into this topic with you today. We are going to completely demystify the mechanics of veterinary ocular ultrasound. Because whether you're holding the ultrasound probe for the very first time, or you're just looking to, refine your diagnostic eye, we are going to break down exactly how to capture, interpret, and truly understand these vital images. Okay, here is our game plan. We'll start with prep and equipment basics, then we'll master the scanning techniques, take a look inside the normal eye, do some exploring in the retrobulbar space, and wrap up by spotting ocular abnormalities. Let's jump right into Section 1, Prep and Equipment Basics. One of the absolute best parts about this procedure is that our patients are usually wide awake, but obviously we need them to be comfortable. So Step 1 is applying a topical anesthetic. We're typically talking 1 to 2 drops of 0.5% proparacaine. Step 2, wait exactly 1 minute for it to actually take effect. Now, if it's a super painful eye, you might actually need to repeat this every 30 to 60 seconds. Step 3 is applying your acoustic gel, and this is vital, okay? It has to be a sterile, water-soluble, lubricating gel with absolutely zero preservatives or scents. We really want to avoid any irritation. And finally, Step 4, always flush the eye abundantly with sterile eye wash the second the exam is over. Now, let's talk gear. The tool you reach for totally dictates what you're going to see. Standard linear probes, which run between 7.5 to 18 megahertz, are going to give you excellent near-field imaging. These are your everyday workhorses, perfect for evaluating the posterior segment of the globe and the retrobulbar area right behind it. But what if you need to see the tiny details of the cornea, the anterior chamber, or the ciliary body? For that, you need ultrabiomicroscopy, or UBM probes. These run at a much higher frequency, 35 to 50 megahertz. So you're sacrificing some depth, but in exchange, you're getting absolutely ultimate high-definition resolution. Moving right along to Section 2, master the scanning techniques. And this comparison brilliantly illustrates what we're actually doing. You can see the physical placement of the probe directly onto the transcorneal surface of the dog's eye. But look at the schematic next to it. It shows you exactly how the internal ultrasound beam fans out from that probe, traveling through the fluid of the eye to literally map the lens and all those deep posterior structures. When you're scanning, you constantly have to visualize this invisible fanning beam in your mind's eye. Real quick, before we look at more scans, let's establish a crucial vocab word: anechoic. In ultrasound physics, anechoic means a structure produces no echoes whatsoever, so it shows up completely black on your screen. In a perfectly healthy eye, this is exactly what we want to see in the fluid-filled spaces, like the anterior chamber, the posterior chamber, and the vitreous body. So remember this rule of thumb. When you're evaluating these specific spaces, black is good. Black is perfectly normal. But hey, we aren't just scanning dead center through the cornea the whole time. By moving the probe over to the limbus, that edge where the cornea meets the sclera, we completely change our viewing window. Using a horizontal or vertical transverse plane from this limbal approach lets us beautifully visualize the peripheral structures. We can see the iris and check out those incredibly detailed striated ciliary processes being highlighted there. All right, Section 3, inside the normal eye. Let's establish our baseline with this beautiful comparison. The globe wall is actually made up of 3 distinct layers. You've got the outer fibrous layer, which is the clear cornea and the white sclera. Then you have the middle vascular coat, known as the uvea, and finally, the innermost layer, the retina. And the cool thing is, when we use those high-frequency probes we talked about, we can clearly differentiate every single one of these layers on the sonogram. Zooming in a bit closer on the anterior segment, notice how the normal cornea appears as 2 discrete hyperechoic, which just means bright white, curvilinear interfaces. So you have these 2 bright lines framing a slightly darker center. Right behind that, the lens capsule is similarly sharp and defined. And check out this space between them. That's the anterior chamber, and it's that nice, normal, anechoic black we just talked about. Moving even deeper, we hit the vitreous body. Normally, this is like 98% water, so it should be totally anechoic. And sure enough, that massive space at the bottom of the scan is a healthy black void. But I want you to look closely at the lens right in the middle. This happens to be a 7-year-old dog. Usually, the internal appearance of a normal lens should be anechoic too. But here we're seeing a bright echogenic center. This is a brilliant illustration of nuclear sclerosis. It's a completely normal aging change where the nucleus of the lens just gets denser over time. So it's a perfect example of an abnormality that is actually 100% expected for the patient's age. Let's keep going deeper. Section 4, exploring the retrobulbar space. Now, what's really fascinating here is comparing an MRI to our ultrasound sonogram. Finding the optic nerve with an ultrasound can honestly be a bit tricky because of how wavy it is. But look at the sonogram. Right smack in the center, you can clearly spot the thin, darker, hypoechoic optic nerve. It stands out perfectly because it's partially encircled by those extraocular muscles, and it's surrounded by all that bright, hyperechoic retrobulbar fat. So why go through the trouble of finding that nerve? Well, it's all about the optic nerve sheath diameter, or ONSD. In normal dogs and cats, this measurement has a very specific range, between 0.91 and 3.82 millimeters, and it scales positively right along with the patient's body weight. You definitely want to memorize that range. Knowing the exact normal size for your patient's specific weight is literally the only way you're going to be able to definitively spot pathological swelling, inflammation, or tumors in the nerve sheath later on. Which brings us to our final stop, Section 5, spotting ocular abnormalities. There is a massive array of pathologies that we can diagnose almost instantly with this tool. Today, we are going to look at visual evidence of bullous keratopathy, where fluid aggressively invades the cornea. We'll see some striking corneal inclusion cysts. We'll look at rare developmental defects like Peter's anomaly, invasive neoplasias like melanocytomas, and the actual structural changes that trigger devastating glaucoma. All right, let's look at some real clinical scans. Take a look at these 3 distinctly different corneal issues. First, check out the feline bullous keratopathy. Instead of those 2 crisp lines we expect, the entire cornea is severely thickened and just packed with these multiple fluid-filled areas. Now contrast that with the corneal inclusion cyst in a dog. There, you're seeing this massive, striking anechoic cavity sitting right in the middle of the stroma. And then look at the intrastromal corneal sequestrum in a cat. The cornea is thickened, sure, but instead of fluid, you see this break, hyperechoic linear interface. That indicates dense, dead tissue. It's amazing how different they look, right? Okay, this one is absolutely fascinating. This is Peter's anomaly in a young 4-month-old dachshund. The clinical photo just shows a cloudy pigmented eye. That's it. You can't see anything happening behind it. But the high-resolution UBM scan tells us the whole story. Look at those echoic strands of mesenchymal tissue that are abnormally spanning directly from the lens straight over to the cornea. The ultrasound is literally mapping out a complex developmental defect that the naked eye simply cannot see. Now let's compare 2 totally different causes of thickening. Look at the aggressive infiltrative limbal melanocytoma, which is a tumor. You can actually see this hyperechoic mass invading full thickness. It's completely lifting the corneal epithelium and just destroying the normal layers. It's chaotic. But contrast that with the scans showing granulomatous scleritis. Here, the sclera is significantly thickened, but notice how it remains uniformly echoic. The structure is inflamed, yes, but the ciliary cleft and the processes below it are respected and intact. So 2 different diseases, but 2 entirely distinct sonographic signatures. And finally, let's look at a true emergency, acute glaucoma in an older American Cocker Spaniel. Remember how the ciliary cleft is supposed to be this open, fluid-filled space for aqueous humor to drain out? Well, in this severe case, the scan shows us clearly that the cleft is entirely closed. The drainage angle is completely compromised. And it's this structural collapse that interferes with normal outflow, leading directly to those dangerous, blinding spikes in intraocular pressure that we associate with glaucoma. So we have journeyed from applying that first drop of gel all the way to diagnosing closed-angle glaucoma, and I want to leave you with this thought. How will mastering these intricate ultrasound techniques transform your own diagnostic capabilities? When a patient is sitting there in pain and their eye is just too opaque to examine visually, this non-invasive tool isn't just a backup option, it is a window into the unseen. So use these baselines, deeply understand the mechanics, and let the ultrasound speak for the patients who cannot. Thank you so much for joining me on this explainer, and keep exploring.